Yeah, so for those you guys who are joining me today, this is the first time we're running, I believe, the webinar in English. This is our webinar number 17, actually, since we started last autumn. It's been great to see so many people following us and signing up for the webinars. Today we have Sally Rafie with us, and I met Sally when I was having a sabbatical year in 2017-18 in California, in San Diego. And my impression there, as you will see today, that you're way ahead of us when it comes to digitalization of medicines management. So that was great to see. And you was, truly a door opening for me to come and learn and see what you were doing. And you were also in Oslo 2 years ago now in May. So that was great having you there. So we thought it was a very good opportunity for us to have you back. You have, a background as a pharmacist. You are very innovative on top of running or being responsible for medication management and medication errors and the whole program, which you will show us today. You're also having you had a clinic when I was there on menopause management for women, and women's health is something that's really close to your heart, and also access to contraceptives in the United States. So there you have done really ground-breaking work, and there's also podcasts with you that people can listen to about that topic. But today, Sally, you're here to give a presentation to us. But before we start I'll just quickly mention to the audience here. Next slide, please. The next webinar will be on October 1st, and it's Camilla Bjørnstad. She's a pharmacist at the hospital pharmacy in Tromsø, and she's also a PhD student at the Center for E-Health Research. You can see the title here, Merarbeid, en forutsetning for integrasjoner i helsevesenet, based on her scientific papers. So just reminding you that the webinars that are recorded can be found online, and that we also are recorded this webinar. So today you have a possibility to ask questions. Please use the Q&A function and ask as many questions as you like. And I think we are ready to go. So then I'll pass the word over to you, Sally.
All right. Thank you so much, Annegerd. It's great to be here with you all remotely. It's nearly midnight here, but it's always a treat to be able to share practices with you all in Norway. Obviously, you've got some different systems that work really well, so it's just nice to be able to learn from each other. I definitely learned a lot during my visit there. So I'll be sharing with you how we use different digital tools in our system at UC San Diego Health. Briefly, I wanted to give you an overview of our academic medical center, focusing really on the hospital space, but of course we use technology and digital tools throughout the entire medical center, which includes, we have infusion suites, we have pharmacies, we have lots of clinics, emergency rooms, etc. But of course, a lot of our focus is within the hospital. So that's what I'll be focusing on now. We have 3 different hospitals at 2 different locations, a total of 808 acute care beds, as we call them, hospital beds. We have over 10,000 employees and over 31,000 admissions to the hospital every year. And as I mentioned, we have lots of outpatient visits and surgeries, almost 1 million of those happening. We are, very large medical center. We are essentially the specialty medical center in the region, and we're part of the University of California health system. There's 5 of us throughout the state, and we have some nice awards. It's a great place to work. I'm very proud to be a part of UCSD. And I wanted to just preface the presentation with kind of this cycle of we design and build our medication use system, and then we monitor, and it's just this constant loop of design, build, monitor, and it's kind of ongoing all the time. It's not, separate steps. So we'll start with some of the design and build of our medication use system. And as you all are aware, there's lots of different folks involved in the medication use system, but also lots of different systems and technologies as well. So although I'm a pharmacist, my role as the medication safety specialist for our medical center really connects with folks in different professions and disciplines. So I will be involved in projects with our nurses and physicians and radiology technicians and nutritionists and anybody who does anything related to medications. So I've organized my presentation in order of the steps in the medication use process. So that's from prescribing to the order communication documentation, products being labeled, packaging and nomenclature, compounding, dispensing, distribution, administration, and then education, monitoring, and we have a catch-all other category for anything that doesn't fall into the others. So I've just included highlights of some of the different digital tools and technologies that we use. Here on the screen, you can see a snapshot of some of our order sets. So these order sets are built out in our electronic health record. We use Epic. And each of these order sets is developed by the experts in the area, and it undergoes periodic review every 3 years. In addition, we make changes along the way anytime it's warranted. And these reviews happen by the specialists involved, usually a physician and a pharmacist. And then it goes on to our pharmacy and therapeutics committee for oversight. And these order sets will not only contain medication orders, but they may also contain lab orders, nursing orders, any type of order. So they're not limited to medications. But we find that order sets are the best way to guide our prescribers, our physicians and other prescribers to appropriate care. We can reduce vague orders. It helps us adhere to guidelines, stick to the evidence-based care. So it's great in that way. Here's an example for the direct oral anticoagulants, which you're probably familiar with. These medications, of course, we wouldn't want to have necessarily overlap, and we have seen some issues with that in the past. So we built out these panels that are indication-based. So as a prescriber comes into order, they can really select the indication. For example, if they want to order apixaban for VTE prophylaxis, when they select that, it guides them to the appropriate dosing for that indication. So it's one way, again, we can guide them to do the right thing, which is always our goal when we're designing the system, is to just make it easy for everyone involved to do the right thing. We don't want to set people up to make errors. We want to just make it as easy as possible. So when they go in to order one of these panels, it will alert them if there are any other existing anticoagulant orders, and will prompt them to remove any duplicate orders, and really helps to, again, make sure we don't get duplicates, reduce those errors, especially with high-risk drugs like anticoagulants. This is just one example of the many, many things we can accomplish with order sets. And with the electronic health record, in terms of prescribing, we have lots of different alerts set up. We have really great technology that can actually look back and see, for example, when they're ordering heparin for a patient. If we already have a PTT that was taken within the last few hours, it actually won't order another one. So we won't get another baseline PTT, for example. So there's some of that kind of brain power built into our order sets, which is very, very helpful. We find that as long as our providers are using order sets, the care is very much in line with our guidelines. When they start to put in orders outside of order sets, that's where we can get into trouble sometimes. And then in the next step in the process, all of these medication orders then come into the pharmacist queue. All of our medications have to be reviewed by the pharmacist and verified before they can be either compounded in the pharmacy, released up to the floor, or the nurse can access from the cabinet. So it's just an example to show you what that queue looks like. And there's lots of different icons in there. For example, the magnifying glass or the little binoculars means that a pharmacist has already looked at those orders. So it's a signal to the other pharmacist that maybe somebody's working on it already. There's ways to put in different notes and different communication amongst pharmacy staff here. And over 99% of all of our doses are reviewed by a pharmacist before being given. There is a very small percentage of medications that are warranted in an emergent situation to be given prior to the pharmacist review, but those still will come into the pharmacist queue. So anything that's removed out of the medication cabinet will still appear in the pharmacist queue so they can retrospectively review it, and there's an opportunity still to monitor what's going on. This is an example of our product labeling for our IV vancomycin, for example, that's compounded in the pharmacy. And all of the information is automatically generated from our electronic health record, except for you can see the placeholders for where the technician who prepared it and the pharmacist who checked it will initial, and they will also fill in the beyond use date. And you can see up in the top right corner there, we do have a barcode. So all of our medications are to be scanned prior to administration. So that'll reconcile it against the MAR to be sure we're giving the right medication. And this is an image of one of our technicians in the pharmacy printing labels for what they're going to be preparing in the hood. And you can see they're obviously gowned up. They have access to the computer to work off of their dispensing queue. And we have technology to scan the ingredients in the IV room as well, along with cameras to take photos of the various ingredients, which allows our pharmacist to check the volume of each ingredient that's going into the bag, rather than just checking the final product or checking a pullback of the syringe, the ingredients. So our codonics system, this generates barcodes for like our batching of our products. So if we batch, let's say, methadone oral solution to send up to our neonatal ICU, we may prepare 20 syringes at a time, and there's just a standard, volume in there, and so they will print essentially what would be comparable to a manufacturer's barcode, where they're all the same. Compared to that vancomycin product that I showed you, that was actually patient-specific barcode. So even if you tried to give that same dose to a different patient, it would alert you it's the wrong patient. Versus when we're batching a standard dose in high quantities like this, then it would be all the same barcode. And this is what those barcodes look like. This example is an acetaminophen oral solution. And this machine is what we use to prepare parenteral nutrition bags. So the formula is programmed in here. This particular machine is obviously not in use, but it will inject the exact quantities of the ingredients into the parenteral nutrition bag, and then that'll go up to the floor for administration. This is one of our robots. So we have some fancy robotics that can be used to make some IV compounds. Here's an inside look inside the machine. And here's our technicians using the barcode scanners for each of the ingredients that's going into an IV compound, so that they can verify what they're putting together. So that's a lot of work in the background to build these ingredients into the system. Everything, all the barcodes have to be scanned in as we receive new products in the pharmacy. So there is some maintenance of that system. This here is what we call our box picker. This is a machine that holds all of our unit dose products, tablets and things for the most part. And this is an inside look through the glass of what that looks like. So all these different bins will contain the various unit dose products, and it will pull for, usually what it pulls for is filling our automated dispensing cabinets out on the patient care areas. So we have a centralized pharmacy model at our medical system, which means that each hospital essentially has one pharmacy that has all the drugs. We may have pharmacists that are out on the floors or covering different units and physically located in different units, but all the drugs are in one place, centrally being sent up to the floors. The vast majority of doses actually are stored on the units in pharmacy maintained cabinets, and that all comes from our central stock in the pharmacy. So this is an example of one of those decentralized medication storage units that we'll use on the floors. This is a cassette system, which I saw some of that being used when I visited in Norway. And we only use the cassette system in our neonatal ICU. We don't use it really anywhere else, but this allows us to prepare medications for patients. Everything gets checked by a pharmacist before it goes up to the floor. Everything's barcoded. This image here shows you we're now in like the distribution. So there's no compounding happening in this room. This is our controlled substance vault, we call it, where we keep all of our controlled substances like our opioids, our benzodiazepines, anything like that that's controlled by our DEA, which is our Drug Enforcement Administration. So for all of those, they're kept in these cabinets, and these are essentially a type of Pyxis machine. And there's very close inventory, of course, of everything here, careful paper trail. And we use this system for unit dosed controlled substances that then go up to similar machines on the patient care areas, on the nursing units. And this technology, we have a software system that allows us to monitor control substance utilization within our organization, which has been extremely useful for. And this here is something that helps us to just regulate or monitor the temperatures. So we want to make sure, of course, everything in the pharmacy and out in our patient care areas, we're keeping an eye on the refrigerator and freezer temperatures. We have a pneumatic tube system in one of our hospitals, which we, of course, have to be careful. Not all medications can be distributed this way, but this hospital has like 10 floors, so it is helpful in going from a centralized pharmacy to get some medications up to the floor in a rapid fashion. This is an example in one of our patient care areas of our automated dispensing cabinet. So you can see we have several different towers and cabinets here. All of the cabinets, for the most part, will either have what we call matrix drawers, which when you open it up is kind of, you can reach in and pull from the different drawers, or we use a lot of what are called QB pockets, which are the locked lidded pockets, and we try to, of course, reserve those for anything that's high risk or look alike, sound alike, because that way, the nurse can't accidentally pick from the wrong pocket. Our refrigerator as well here is locked, so they do have to select the medication from the system to be able to access the fridge. And then in the tower there, we have more bulk items that don't fit as well in the smaller cabinets. And we have a short list of medications that are accessible on what we call override. Everything else has to go through the pharmacist review before the nurse can ever access it. And when they come to the cabinet, they actually will select their patient, and then it displays a list of the medications that are available for that patient. So they don't come here and just pick a medication. It's all patient specific pulls. And this is just showing you how I access the cabinet. It's with a fingerprint scan. This is an example of the locked lidded QB pockets. So you can see each of these has a barcode. Our pharmacy technicians will use that when they're loading the machine. The nurses scan the barcode on the actual product. So the barcode on the clear lid there, that's used to just scan the product to the pocket. We can see we keep unidose packaging in here as well as vials. Everything is labeled and barcoded. And this just shows you, it just pops open the one medication. So it'll pop open the drawer automatically and then pops open the lid. So the nurse doesn't have to choose anything. This is an example of the same type of locked lidded pocket, but it's a deeper one. So there's different heights for the different drawers. And then this is the matrix drawer. So it's more of an open cabinet. You can see how the nurse would be able to pull different things in here. We would never keep controlled substances in here. All of our controlled substances are in individual locked pockets. And this is what it looks like on our MAR, our medication administration record. Each order is displayed here with a MAR action for them to chart against when it's due. There's some additional information you can see for the carvedilol there. There's some admin instructions. It says hold dose for systolic blood pressure less than 90, etc. So we'll sometimes have additional instructions there. This is just one view of the MAR. You can see all the tabs at the top there. These are the due meds, but the nurse could then go to PRNs or go to pain meds or, you know, override pulls, all these different things, different ways of looking at it. And this is what the patient room looks like with the barcode scanner. So every room has a computer in it where they are doing all their charting, and it also has a scanner that they scan both the patient's wristband and the medication barcode. This is an example of a really cool technology that we actually built in our electronic health record. This is our insulin calculator. So for patients on a continuous insulin infusion, it's actually completely managed by this calculator. It's our own homegrown formula. The nurse will put the blood glucose result in here. They'll answer some questions on, you can see with that red exclamation mark in the middle, nutrition on hold or decrease since the last entry. And it gives some examples of that, and they'll say yes or no so that it can adjust the equation. And it actually will then tell the nurse whether bolus is indicated and how much, and then also what to change the infusion rate to. So it's really smart. It's really neat. Eliminates having to go to a different system. It's all within the MAR there. These are our smart infusion pumps. We have 2,500 entries available in our library, so we can build out continuous infusions, intermittent infusions, PCAs. That's all built out here. Each brain allows for 4 modules to be attached to it. This is an ICU patient. They obviously have 6 different infusions going, so they needed 2 brains. But each of those medications are built out and allow for default concentrations. We can put mins and maxes in there, alerts. We can do like a soft max, which just alerts the nurse that you're hitting the max, or a hard max that you can't bypass. You can see on each of those modules, there's the drug name scrolling in that thin panel. So we have a piperacillin tazobactam, we have a fentanyl going. The other ones look like they're not on right now. But we want all of our medications to be infused using the smart guardrails because there's some added safety there. One future technology is to integrate this with our EHR so that when they're scanning a med, right now they scan the patient's barcode and they scan the medication. There will be one additional step where they will scan the pump, and it will pull the information in from the chart. And so the nurse will just review it and hit OK. So they won't have to do any programming, which really eliminates like decimal errors or different things. And it also helps with documentation, because then it also will populate back into the MAR where the nurse just has to acknowledge the information. So something we've been working towards and looking forward to getting that when we have it. So lots of different technologies along the way. Again, this is some of what we have. And of course, nothing is perfect. Everything has its holes. So anytime we're bypassing any of these steps, it's more likely that the error makes its way to the patient. So now I want to talk a little bit about the monitoring piece of it. As I mentioned, we're continuously monitoring everything that's going on, lots and lots of different data sources. Our primary source of data is our voluntary medication error reports. We get about, I would say, somewhere between 120 to 150 per month. And those errors we know are just the tip of the iceberg, but we still get a lot of really valuable content coming through there. So we use a electronic system for our event reporting. You can see here, it looks a little bit like an Apple type screen where they will pick the corresponding category. Medication error, of course, down in the yellow mortar and pestle there. And it just asks for some basic information, and that allows us to really follow up on things, document, just a really great system. And then we also have used Tableau, which is another software to allow us to do some real-time monitoring. This is of our event reporting system, but we use it for lots of other things too. So you can get real-time data to share with frontline staff in terms of like where things are happening. For example, we use it for our barcode scanning in the pharmacy when we're compounding. So we can see if there's like a medication that's not scanning well, or if there's an individual who's not scanning. So it's really great for real-time input. Other things, we basically pull data out of all those systems I just shared with you. We pull from our electronic health record. We pull from our automated dispensing cabinets. We pull from our barcode scanning rates. We pull from our smart pumps. So we're monitoring everything. Of course, if we notice something is dipping below target, we often have to do additional drill down. But it's nice to just have a gauge of how we're doing with all of these. Another thing we do is triggers. So anytime, for example, we give a patient naloxone, we do a chart review. That's very cumbersome. I wish there was a better way to automate like identifying when it's just a, you know, of course things happen. So whether it's an adverse effect of something versus an error. But for now, we have to have humans reviewing that. And sometimes it's a soft call between whether it's an error or an adverse event reaction. And I want to share our dashboard with you. This is our most recent dashboard for our Safe Medication Practices Committee. So we track everything on a quarterly basis. Some of these things we're viewing more in real time, like for example, barcode scanning in the pharmacy. We're looking at that on a weekly basis. We're showing barcode scanning that our nurses are doing on a monthly basis, but we collate everything for committee review on a quarterly basis. And we use colors to indicate green means we're at target, yellow means we're close, but not quite, and red would be if we're more than 10% from target. And you can see how we've organized it. We don't use colors for our medication incident reporting because we don't necessarily have a target with that. It's more qualitative than quantitative, so we don't put metrics on that. But with our utilization of our different technologies that I just reviewed, of course, we always want to use the technology. Even if all we're doing is giving a patient normal saline, we still want to scan it. We still want to use the smart pump, all of that. And we also will look at where the errors are in those different categories that I shared with you. And we look at errors in general versus those with harm. And this is all very interesting, but I can tell you that it's still not as actionable as when we look at the individual events and look at them qualitatively. However, it is nice to just monitor quantitatively as well. And we use the PDSA model for all of our improvements. We have a very robust medication safety program. We have 12 different subcommittees that review the medication errors that are being reported in their areas. So we have one for obstetrics, one for the neonatal ICU, one for adult ICUs, one for the emergency department, and so on. And each of those groups has at least a pharmacist, a physician, and a nurse. And they all get together and they review all the medication errors that have been reported in that area. And they determine, is this a system weakness? What can we do about this? And we have lots and lots of improvements going on all the time. So lots of like kind of small, quick things happening. And then we'll have large initiatives, some of them that will span a full year or sometimes 3 to 5 years. So it just really depends on the scope of what we're trying to accomplish. And we always try to keep in mind that education alone is not a very effective strategy. So we always try to think about, is there a forcing function? Is there a way to automate this? You know, really looking at more effective strategies to reduce errors. We will also educate, but I always say education has a really short half-life. So we don't really want to depend on that. So that's quick overview of some of our exciting technologies, but I'd love to see if you have any questions or would like to discuss anything that I've shared here. And of course, I'm happy to share anything else you have questions about as well.